Welcome to the Vet Med Wellness and Leadership Podcast, where we discuss central challenges vet med leaders face, such as burnout, stress, and difficult interactions with clients and staff, just to name a few. In each episode, you will hear about actionable solutions that you can apply to your practice and invitations to connect with fellow leaders who are passionate about improving the wellness of the vet med profession. By subscribing, liking, commenting, or sharing this podcast, you are helping more veterinary professionals find the resources shared in these episodes. Thank you in advance for listening and supporting this show. I hope you enjoy it. Hey everybody, Crystal Stokes here, and joining me today are Dr. Emily Gould and Dr. Kate Aicher. Did I get it right? Yes. All right. So we're here today to discuss the topic of intellectual bullying in vet med. And I'm going to just take a brief moment to let each of you introduce yourselves because you both have a really rich background. So I'd love to just pass the mic over. Let's start with Emily.
Thank you so much, Crystal. We're so excited to be here. This is a topic we're really passionate about. And so just thank you again for the opportunity and having us on the show. We're stoked. So I am a small animal internist. And I did my undergrad in vet school at UC Davis and then spent some time in private practice in two different private practice internships, rotating in specialty. And then I was at the University of Tennessee for about 5 years total, did my master's there, followed by my medicine residency. And then came to Texas A&M in 2019 to finish up some other graduate stuff and then just ended up staying as a faculty. And I think that for me, I'm really passionate about this topic, had some kind of formative, experiences during my training program, as most of us probably would say the same thing, that kind of shaped some of my early thoughts around this topic. And then I think stepping, from that trainee into the faculty role, all kind of during COVID is when I was making that transition. That really sparked a lot of interest in how we as human beings talk to each other and interact with each other in the profession. And I am very involved, as is Kate, and she'll say in her intro, with our house officer, so our intern and resident well-being committee. And I think in medicine, we tend to focus a lot on the didactics and the facts and the numbers and the medicine, right? But there's this whole other component that's important to how we practice medicine. And that's kind of what we're here to talk about today.
Awesome. Thanks for the intro. And how about you, Kate?
Hi, I'm Kate Aicher. I'm a small animal internist. I'm originally from North Carolina, but I went to vet school here at Texas A&M. And after vet school, I went to do my small animal internship at University of Tennessee. And then I did a residency in small animal internal medicine at NC State. And then after my residency, I stayed in North Carolina for about 5 years where I joined a big emergency and specialty practice, 3 hospitals together. It's really big, probably 250 or so people, and joined as an internist and a really great group of people there. And then subsequently got to become a service chief and then medical director all through COVID. So I think COVID taught us a lot about people and breaking points and problem solving and innovation. And so I got the opportunity in that position to see a lot of the stressors and the human being experience that goes along with that, which I learned a lot from. So I really appreciate that time. I returned to the mothership here at A&M in 2021, just so I wanted to kind of get back to grassroots with mentees earlier in their career and their journey. That was really rewarding for me. So came back here in 2021 and I've been here since. So I get to do, a combination of things like I'm on the clinic floor seeing cases and teach vet students and have mentees that are here as well. And I think that we spend just as much, if not more time mentoring them in all of the rest of the job and professional skills and leadership and emotional intelligence. And all of these things are so important to thriving in veterinary medicine. So it's nice to see that shift over time, but part of that. And this was, a topic Emily and I, probably half of our friendship is based on shared passion for these kind of things. So it's great to be able to talk about this more broadly.
Wonderful. And just shout out for NC State Wolfpack and just North Carolina in general. I was a NC State and North Carolina, not native, but almost native. The South, we all kind of blended together.
Not for anybody that's on the call today that might be thinking, go North Carolina.
Yeah.
So how did you all become interested in the topic of intellectual bullying? Like, how did it come on your radar? Because I think many people tuning into this might say, I've really never heard of this. What the heck? So how did you become interested and so interested that you end up going this deeply into it?
Yeah, so actually, well, I think it's a pretty cool story because I think that it illustrates the point of a few things. But we, every year for internal medicine, we go to this big annual conference that's in a different location, usually each June. And we were at one in 2023, right? That was in Philadelphia. And Emily and I are also like typically overcommitting ourselves to things when we go to these conferences. So it's a big conference. We were in different places. We actually really minimally crossed paths, but we were attending sessions. We were moderating sessions, judging abstracts for trainees. And when we came back from Philadelphia and we got back into town, we always go on these long walks with my feral Labradors. And they had cabin fever from me being gone that week. So it was like perfect timing. And we went on this walk and we both had said like, holy smokes, I have so much to unpack from this experience. And as we walked around, normally coming back from CE events, you're really feeling pretty packed full of knowledge. You've met with collaborators, you're inspired, you're really more excited about practicing. And we came away from this not feeling any of those things. We felt more just exhausted by the human experience, and that we had a number of really similar observations of people just really not treating each other very well or respectfully or collegially or just, like basic human beings. And sometimes that happens like one spicy person or so, but this was something that it was just prevalent, and it was in every session we went into to some extent. And people walked away from the sessions thinking more about just the people interactions than actually what was being discussed. So we talked about it, and then we thought, well, gosh, what if we brought this up as a topic? And we made a formal presentation the next year at the place where we actually were impacted by this. So we somehow talked ourselves into this, and we had the Labradors as our accountability partners for doing this. And so by the end of the walk, we were like, well, we can complain about stuff and nothing changes, or we can actually try to do something about it. So we put a proposal together, which also was a lot of work because it was a difficult topic. And we got it approved, and we got the opportunity to give the talk. And I can let Emily describe more about what that looked like, but it was worth it. But it was a boatload of work to get there, but really impactful.
Yeah.
Yeah. And we're really happy, that we ended up doing it. Like, I think that there was a couple moments there where we were kind of like, ooh, this might not align with the vision of what the organization, might be ready for us to talk about. And I think at the end of the day, it turned out phenomenally. There were multiple people from ACBIM leadership there, probably to make sure that we weren't too out of line with what we were saying, because it is such a new topic, and new is scary, and it's unknown, and it's risky too when you have a huge group of people. And there at our presentation, when we were kind of giving it, and we were doing it in a lunch hour, in kind of an exhibit hall, because there are some talks that are given in an exhibit hall. And I'd actually asked a neighboring booth to please turn on their volume. And they kind of looked at me like, what are you? It's an unusual request. And we were floored by the amount of people that turned up. And I think the broad range of, from trainees all the way to front desk staff, I think, comprised our audience. And Dr. Sarah Gillings, who is, I think she still has a large role in ACBIM leadership. She's an oncologist, met her right after our talk. And she had said, I'm going to connect you to Crystal. And here now we are sitting here talking about this. But really after that point in time, we've given not in a podcast format, but in a lecture format, in a couple different ways to a couple different audiences since our original presentation, ranging from private practice to our own preclinical veterinary students. We talked to our third years about this, and it's been really fascinating. And we're going to go through this, I think, over the next 50 minutes as we delve more into this topic. But what has been so powerful, I think, for the two of us is it doesn't matter like what group we're talking to, everyone relates in different ways. It seems to be a universal type topic. And when Kate and I were talking about doing this presentation, we're like, wow, okay, like what the two of us are here talking about this. We could be really brave and do it, or not do it. But I think what really probably ultimately pushed us to do it was finally being in a position where we're not trainees anymore, and we have a role now where we have decisions to make about how we shape that conversation. And so that's been like really like powerful for us, I would say. And going back to what Kate was talking about, with our friendship, like I'm really excited to share this passion with her. And there's no way in hell I would have done, this talk alone. So I think that's been rewarding for both of us.
Glad you have each other as wing women.
Yeah.
Look, let's start with just a very high level overview for those who have never heard of intellectual bullying. High level, why does it matter? How does it contribute to things that we might care about, like patient care, turnover, just to kind of, link it in. And then we can dive into the main points of, the kind of highlights of what you covered in that presentation that you all created.
Yeah, well, one of the things that we did when we just started this topic with the audience was actually to just like put up a word cloud, and because we were really curious to know what did people think about this. I think people frequently, and part of our pre-planning, we thought people really can easily identify as being the victim, but we were really curious to see if anybody would be able to reflect within themselves to say, well, am I ever part of the problem? And if so, does that come up under certain circumstances? So when we did the word cloud, we found it changed a little bit like per group for them to give us an idea about what they thought about. But some of the big things that came out were things like power. I think that was really important because we think about the dynamics within the hospital themselves, or, here in the teaching hospital, or really any work circumstance is going to be power differentials. And that's really important, I think, because we have to think about that in the context of the interactions that we have. More so than we might give credit for, things like belittling, shame, mean. Those were some huge things that came out. So those were some immediate associations. And what was interesting is we also would do some scenarios. So we had some filmed scenarios or some words or phrases, and this was sort of the opportunity to get kind of a pre-test with our audience to see which of these scenarios, when we crafted these scenarios, we felt like they all fell along the lines of bullying somewhere. There were just very specific nuances about each of these interactions, whether it was the power differentials, the timing of the conversation, the setting, the specific words or nonverbals, all these things came into play. And so we would do a pre-test, we'd show these scenarios and ask people for feedback if this was an example of bullying or not. And then would get into this debrief about, how almost any of these conversations were things that belonged in the workplace. And in fact, perhaps were even important in the workplace and could build positive culture and community in the workplace. And yet there were very specific parts of each of these scenarios which made them problematic, but in varying from like everybody would agree this one is problematic to this one's subtle and we wouldn't have a lot of agreement. So that was really interesting going into that. And so I don't know if we should, like, Emily, do you think should we talk about a couple of those scenarios just to like set that? I don't know, Chris, I think that would break.
Yeah, I was thinking about the one you were talking, and of course we'll have some people that are watching the video of this, but probably most of the audience will be listening. So Crystal, feel free to jump in. Kind of maybe we'll do two different dichotomous scenarios, and by dichotomous I mean we will do scenario one in two different ways, and I'm going to set up the first one for you, and then we'll, debrief on it, talk about it a little more, and then do scenario two. So let's just start with the first scenario. In this scenario, I am a licensed technician. I'm working with Dr. Aicher, and she has asked me to get some butorphanol sedation for our patient Frosty for an ultrasound. And in going to pull up the drug, I am unsure of the dose that's written, whether that's I can't read the handwriting or, Kate wrote it very quickly because she was getting interrupted by many things or whatnot. So I am going now to approach her about the dose. hey, Dr. Aicher, I was going to pull up Frosty's dose of butorphanol for his ultrasound, and I really don't want to delay his imaging happening. However, I wanted to confirm something with you about the dose. Would that be okay? Do you have a moment? I know I'm interrupting you.
Yeah, look, Emily, I'm sorry. Can you just focus on, you do tech things and I'm going to do the doctor things because I went to vet school. I put in the time and the hours. What you do is great too. But ultimately, like if I put that dose, that's what I meant. Just pull up the dose and give it to the dog so we can keep moving on today. Does that work?
Okay.
Great. And I can just narrate real quick for the people that don't have the video. The main thing I noticed was that with Kate in the doctor role, as she was talking, she was kind of shaking her head back and forth, kind of in a no way, and a little bit of kind of like a head forward, like you're pecking towards somebody. And then Emily, as the technician, was just kind of nodding along, like okay, and in agreement as Dr. Kate was talking.
Yeah. And so I think if we flip this scenario, so now we're going to do the mirror, opposite mirror, however we want to say it, of the same scenario. So again, same setup. I go to Dr. Aicher. Hey, Dr. Aicher, is going to pull up sedation for Frosty. Do you have a moment? I'm sorry to interrupt you, but do you have a moment where I can just clarify something with you about the dose?
Hey, yeah, let me just finish this. Okay, perfect. Let me see that form. Oh, look, it's my terrible handwriting. Again, I am so grateful that I worked with you and you are so willing to check in on these. Yes, that should be a decimal place there. Thank you for looking at that. Don't ever hesitate to come tell me again on a day like today where I'm just trying to keep the wheels from coming off the bus. Like, this is going to be a team effort. Thank you so much.
Absolutely. And again, I feel so bad interrupting you, but I didn't want to delay him getting to imaging. And yeah, this day's crazy. I mean, I feel like this week has been a lot. Today's been a lot. And I just wanted to make sure that we were double checking each other, and we'll get through the rest of this day as a team. And I'm thankful for you. All right, I'll go make it happen.
Awesome.
All right. And in this one, there's a lot more like head nodding from both people, more smiling. It looked like softer facial expressions. And interestingly, I was kind of watching the time. I think both those scenarios took almost the exact same amount of time.
Yeah, that's I didn't even think about that. That's a great observation. Yeah, so maybe we'll just take a couple minutes now before we go into the second set of dichotomous things to kind of debrief and unpack that first scenario.
Sounds great.
Yeah, the first scenario, that was so like not my person that drained energy from me. But if I were to try to find like what is Kate's perspective at taking that approach with a colleague, would be the questions I might think about were, what was their relationship like before? Is Emily somebody who has previously come to her with 100 concerns? 99% of them have been ones that weren't a problem, which I still think missing the opportunity for a drug error, the consequences of missing that is catastrophic potentially. But I wonder what their background would have been like before. I wonder whether or not Kate was feeling any sense of like imposter syndrome or questioning whether, what is she thinking, or what have her interactions been like so far in her day-to-day life? Are those the things that are coming to mind? And maybe she's walking away thinking, everybody thinks I'm a terrible veterinarian, and has to double check behind me on everything because they just don't trust me. What are those things that she might be thinking about? And I don't know.
Yeah. And I think that there are some scenarios, especially for emergency clinicians in an emergency situation, our ECC colleagues. I think Kate and I have thought about this a lot, as we've been having conversations within our hospital about this. There are times where you got to be direct. You got to, there can't be interruptions in certain things, but I also think it's all in how you maybe communicate or set up the inevitable scenario that's going to happen like that, where there's going to be some emergency situation. You might have to be more direct, and people might get offended or think that's rude. But it's all in how it's approached, I think, before, and then if not before, a debrief and a conversation after of, hey, that combo didn't quite sit right with me. You know, like, are there other things happening with you? I really want to hear, you know, what was your interpretation of that, essentially?
So I think Emily might be like, Emily walks away from that. And what are the two things that she might do going forward? One would be maybe she's immediately going over and updating her CV and applying to her new job. Maybe she quits that day, you know, and you've got one less team member, which means that's one less set of eyes on patient safety things. Or also, like, what if she's like, well, I'm never going to go and double check this dose again. I'm never going to go through that humiliation, and I'm just going to pull up these doses that may or may not hurt these patients. You know, that's absolutely not what we want either.
Yeah.
So these are really important conversations to have.
Yeah. And I think possible erosion of trust for a lot of these scenarios, not just that scenario, but I think the second one that we're going to talk about also could say the same thing about trust erosion between those individuals if an honest conversation hasn't happened. So let's maybe move on to the second set of the second scenario with the mirrors. And just to set this up, so in this scenario, both of us are going to be veterinarians. I'm an early career veterinarian, so maybe a year and a half out. So anyone listening can think back to that stage of their career for the vets that are listening. So I've just finished a really busy week, a really busy day, but I'm overall feeling good about the cases, feeling good about my general progress. It's about 4:55 or 5:55, the end of the day, whatever that looks like. And I am, you know, just finishing up my records. I'm at my desk, and Kate is approaching me as practice manager, so a much more seasoned veterinarian. So she is entering the scene as I'm frantically typing.
Okay. All right. So yeah, end of the day, Friday. Emily's working on her records. Okay. Hey, Dr. Gould, I just hang on. Let me just finish texting about this. Yeah, I'm gonna pick up the kids. Yep. Okay. Bye. Okay. So yeah. So wow, what a day. I wanted to let you know we are getting tons of requests for Saturday urgent care appointments, and you're our person holding down the fort on Saturdays. And you know, you've been out a while. I know we were trying to be real careful about how we were scheduling you, et cetera, but you know what? You're doing great. And honestly, when you know, Dr. Brown started, by this time, we were really loading these Saturdays and taking care of what our clients needed. So what I'm asking is, I think we're going to go ahead and start scheduling some urgent care appointments on top of the wellness appointments that you have on Saturdays. That's what our clients want, and we just need to get them in. And you've got this. Like, so I've gone ahead and started this. We're going to start this tomorrow morning.
So tomorrow?
Yeah, tomorrow. Yeah, tomorrow morning. Yeah, that'll be fine. Anyway, so you've got this. I feel it's going to be great, and our clients are going to love it, and you're going to do great. And the team is so happy that we're going to see these cases. So I'm going to go pick up the kids. So I'll see you. I'll bye. Yeah.
Okay, bye.
Wow, that was great. So for those who can't see the video, you've got to go on YouTube and watch the video. So as Dr. Kate was delivering this great, not great news, you could see Emily's face, like her eyes were getting really big. Her jaw was dropping, like, seriously? Starting tomorrow? And her voice is going up.
That was the turning point, the tomorrow. Like, I was kind of like smiling and on board until then.
That's right. That's what I was like, this is too much. And then watching how Kate just continued to really push forward with, it'll be great, like completely invalidating Emily's experience and just staying very sunshiny and positive, like, it'll all be fine. And then bolting out of the room, she literally like left the room. She left the Zoom room.
So I was like, wait, I was gonna ask, did I miss an email about this? But she was already gone. So
gone.
There was no time.
Opportunity for questions there.
Yeah.
To drop and run.
Let's do the mirror. So let's do the mirror scenario. Same scenario, same setup. So we're the same roles, and I'm frantically typing at the end of the day.
Hey, Emily, holy smokes. Is it a full moon? Like Friday?
Oh, geez. I know. And I've barely seen you all week. It's insane. It's just been a wild week, but we're getting through it. We're almost there.
Yeah. Well, you did great today, which is on a background of doing great. And I realized when you started, we talked about incremental goals and thinking about how do we keep trying to challenge you to keep growing so that you get those challenges you were looking for. You talked about wanting to come into a practice where you could start to crank up what you were doing or impact or kind of the versatility in how you were working within the practice during this time. So I was just thinking, and I'm going to tell you this just for something to think about, right? And then we can regroup. So just kind of think about this. No need to give me feedback on this right now. It's the end of the day. But ultimately, I think that we have a lot of clients who are looking to try to come in for urgent care types of appointments on Saturdays. And also Saturdays are when we have clients that, are off work and they can come in for their preventative care. And I know we've been cruising along and sometimes we have those emergencies, but I wondered about trying to come up with a strategy where we got those cases in early while we had the team refreshed and had more hours in the day. And the thing is, you're doing great. Like from the outside, having mentored other doctors before, I know you're ready for this challenge. I know that you probably don't feel that, and that's natural. That's how I felt at that time as well. But I wonder what that might look like if we did something like that. So I wanted you to think about that. I know you're on tomorrow, so you could even think as you come into the hospital tomorrow, what does that look like on a Saturday? If those variables were added into the day, think about it. And then let's reconnect to the beginning of next week. And even if we did this, if you thought that it worked, then we need to probably figure out how to ramp the team up to that. And I'm thinking maybe we would do something like, would we look to try to make that change in 3 to 4 weeks or something so we could plan towards it and figure out how to succeed. But mostly, I think you're up for this challenge. Like you're doing great. Like you're exceeding all of our expectations. And I want you to have some control in it. But I think you'd be ready for this push if you felt the same. So just wanted to give you that to think about, and then we can reconnect and talk about it some more.
Thanks so much. Wow. I was not expecting, I think, to hear that at the end of the week, but what a great way to end the day. And I just thank you for kind of thinking about this, putting a lot of, forethought into it, and also giving me time to reflect and think about how this would look and what would work for me as an individual. And it's funny that you're coming up to me right now because I was already kind of thinking, I need to make sure to get a meeting with Dr. Aicher on the books just to talk about how I am feeling a lot more comfortable, a lot more, confident. I think, as we know, surgery has been an area that really I've needed the most growth in, just because I'm not the surgically minded person, but I am proud of kind of how far I've come. And I am so grateful for your mentorship and the other, all of our colleagues here and the technician team who are fantastic. And I'm just feeling a lot better about the flow of things here, communication on our team. And just thank you, because I don't think that I would be at this point without mentors that really cared. So that sounds great. I would love to try to start challenging myself more. Because the recent growth, I think, has felt good. And so I will reflect on things on my days off, and then we can regroup if that sounds great.
Yeah, that sounds wonderful. All right. Have a good night.
You too.
So that was so much more reciprocal, right? There was balance between each person had time to talk. It felt much more even and just had a warmer vibe.
Mm-hmm. Yeah. And I'd
like to share too real quick how so often I think that part of what's behind the bullying aspect, what appears, to be pressure, time pressure, we're rushed. We feel this like urgency all the time. And I especially see it when I work in emergency, and that's where I kind of cut my teeth too. Some are kind of wired that things are even extra, extra urgent. And the interesting thing, and I definitely have come to appreciate this more and more as a therapist, that what appears fast initially actually takes so much effing longer. Because in that first scenario, if you had kind of pressured her into doing it and just threw her in, yes, initially you're going to see more patients, but then you might lose a doctor, you might lose techs because they're like, hey, there was no plan. It was top down delivered. It makes us feel like we have no power. We're not even part of the process. You don't value us. So you know what? We're going to kick rocks to another clinic. Now you're down and you're seeing fewer patients. So in the long run, like you're not really hitting your goal of growing your team, solidifying your team and seeing patients and keeping that consistency. So you say go slow to go fast. It actually really does work. And the second scenario, like I think what was so beautiful about it is you're enlisting her, the newer doctor, in the process so she can see how you're thinking. You can think through it together. Like, what are all the moving pieces? And you're thinking about it systemically about how will it affect the technicians as well. And what are the other parts of the system? It's not just the doctor showing up and saying, I'm ready to do it. And her confidence, there are other moving pieces that contribute to her confidence and abilities. So I think that was a beautiful lesson in how as a leader, you can help others evolve their leadership capacities by taking the time. And again, in the long run, that will speed things up because now you have a doctor that's leveling up with you on her leadership capabilities too. And that will bleed down to the whole team.
Mm-hmm. Yeah. Absolutely. And thinking about like you referenced the emergency room and we said that, 7 minutes ago, talking about emergency ECC type, critical care type situations. And there is no doubt there's urgency in those scenarios and when you're literally life or death. But I think that we as much as we can do the work in the beginning and set a good foundation with teamwork, you're going to save so much of it on the back end. Yeah.
Totally. Well, I know next we had this kind of shifting into broadening how we're looking at all this and kind of moving in maybe to the area of like the psychology of behavior. Do you want to shift into that now? Okay.
Yeah. I love this part. Actually, I have to give a shout out to somebody who was on the ACVIM forum planning committee who had really made us bring this into the conversation, which I think is a really important part here, which is that it is really easy for folks to be able to identify as victims, and it is really hard for people to identify as a bully. And so he had encouraged us to think about how to think about people as the bully and how to be able to describe it that way. And I also think that it's really easy to jump to the worst narratives or explanations of things. But if you can actually put yourself in the position of the quote unquote bully, then it might be that actually you can find humanity within their behavior and a solution on how to get to it. So the psychology here would be thinking that it's something that I think we all know what harassment or discrimination is. But this is more a matter of influencing change in a more kind of forceful way. And that can be anywhere from the spectrum of just your nonverbals, the power differentials, the setting in which you have the conversation private versus out in public. It can come via email. It can come via conversations, text messages. There's just so many different ways. And I think the hard part is that while there are legal definitions for things like discrimination and harassment, that bullying is something that I think every single one of us can put our finger on or describe that it's happened. But if somebody were to be like, define it so that we can then write a policy and hold people accountable to it, that part is a moving target. And so I think it's part of it is thinking, can we describe that there's intent and can we prove that there's intent? And so that's really hard for both holding people accountable or really trying to be able to put a finger on it. That one of the things are that it seems like some people, it's very comfortable for them to come forward as a bully immediately. That's just their default behavior for everything that they're navigating in their professional or personal lives. And then there's also people just are going to default to this behavior under extreme circumstances where it comes out of need. So I think that was really encouraging to think about. And when we think about if I were to say that there is not a single human being amongst us that is immune to this behavior and that there's a bully inside every single one of us, even the kindest, most compassionate person, that there is a bully within them, that might be hard to believe, but I do genuinely think that it is true. And so examples of this would be, for example, hearing about people's perspectives on if they've been able to identify this within themselves, how did it happen? So maybe it was something where they were asserting their will on somebody else in a workplace in vet med because they were standing between what they thought was a patient safety event or, something that was going to hurt the patient, and that they started to precipitate the sort of more dominant behavior or assertive behavior or pushiness that would happen. We had a clinician that we worked with here who was really just a fantastic person, so enjoyable to work with. It's hard to even think that there was ever a time in her life where she wasn't this way with every single human being. But ultimately, she got a lot of feedback because the technicians that cared for hospitalized patients were finding it increasingly difficult to work with her, that every time that they contacted her about a patient question or concern, that they felt decapitated. It was very much like that first scenario that Emily and I were describing. And that after sitting and speaking with her about it, because it became to the point where basically technicians weren't going to work with her anymore, which was incompatible with, with our hospital environment and care for our patients, was that she basically thought that the more that she cranked up this behavior, the more that she asserted her will, the more direct she was in communicating, the more likely she was going to be able to advocate for what her patients needed. And when in fact the complete opposite was true, that the more that she brought this behavior into her communications with the team caring for her patient, the less likely they were to contact her to talk about even a subtle change. And when she reflected on this and really made change, it went entirely the opposite way, where not a single technician in the hospital would hesitate to reach out to her, even about concerns for other patients, that's how much of a difference that it made. And I also think that some people, it's a self-protective behavior. So perhaps it is they're suffering from imposter syndrome, or they're worried about their job security, so that they're really trying to make it seem like this is their area and this is their expertise and don't question this. And that I think those things come into play. Somebody else we spoke to before doing the talk was talking about how he wanted to command excellence in the vet students and the trainees that were with him. So when they would round about cases, he would come in really what is the pathophys of this? And why don't you know this? And that he thought that would command excellence and foster growth, because people would just come in sort of scared with these rounds and really over prepare. And when he have reflected on this part of his career, he realized that he probably had actually undermined that goal itself and just made it a place where people came in and were less capable of thinking and speaking safely, and that people don't learn that way effectively. Like some might, but many don't.
Mm-hmm. It's not brain functions when you're under stress, right? That part of your prefrontal cortex that does a lot of logic and reasoning kind of just shuts off. It access. So you're not going to learn and you're not going to do well when you're in that heightened state, right? The other brains like fight, flight, freeze, just basic body functions. That's the one that's just taking over. So you're not going to retain much. That's why people get like type of amnesia too sometimes under stress. Like, I don't know the details. My heart was beating really fast.
Yeah. Well, and that's actually, Kate and I have talked about this a lot. And I think that was one of our big whys for why we submitted it to ACVIM was oh my gosh, we are spending more time thinking about that interaction than the scientific session that was presented. And the same thing happens every day in daily life. And we're talking about teaching hospitals here, and not just teaching hospitals, but, everyone in this profession is a teacher at some point, right? You're a learner in the early part, whether you're a technician, a client service representative, a veterinarian, whatever it be. So it's a natural progression that you're going to be mentoring someone or in that leadership position. And man, you might be really having the opposite effect. And I know we're going to get into impact soon, but the other thing I was going to say on the heels of what Kate said, in human medicine, there are studies on this. So actually one of the kind of references that we provided with this podcast session is a really nice large review, Averbuck et al. And it's looking at what are the common threads and the most cited perpetrators and then victims of this bullying behavior. And I think unsurprisingly, there are high amounts of male surgeons in general. And we think about stereotypes of people. But that kind of makes sense to me because that's a specialty that is highly sleep deprived, on call after hours, interacting with a large amount of people. Same thing for internal medicine. So internal medicine and surgery were actually highly cited. Males, individuals with higher body mass index were reported to feel more targeted or treated differently. And then I think it makes sense that international individuals or individuals from other cultures, also at least in the human, academic setting, have been cited to be more likely to report being recipients of bullying behavior. And that makes sense, right? So we think about nonverbals, we think about cultural norms, we think about ways of communicating that are so different as you start to look on a global basis. And then another thing that was really interesting to us, but maybe made some sense when we parsed it out, was more senior professionals were more likely to report being victims of bullying. And I think there's a couple potential reasons for this. Number one, they're more senior in their career, so they've had more time to experience that. Number two, they're out of the whole power differential thing, right? They're at the end of their career. They're like, I'm already promoted, or I'm just over this and I'm willing to speak up about it, and I'm not scared about retaliation. So I think all of those are possible explanations. But what's interesting, and this is just popping into my head, and Kate's going to laugh that I'm bringing this up, that show The Pit on Max. I promise I've not been paid by Max to promote this at all, but it's quite an excellent medical show. And, as Kate was talking, I'm just thinking about, there's a character on that show, Santos, I think she's an intern, and there's, multiple scenes in the first couple episodes where she's trying to bond with, a med student or, someone junior to her. But we have to think about all these power differentials. And so I think going back to the stats that I've just cited, it is, the intent might be positive, but the impact might not be positive. And so I think then we can transition into impact in a second, but then it really does get into, individuals educating themselves, especially those that are in teaching leadership positions, leadership roles, and also thinking as a recipient of bullying, there is a partial onus on you to, try to have a face-to-face conversation with the person. I think the pinch point is power differentials make that really hard in our setup.
I wish we had 2 hours for this podcast, because there's so many parts that we'd love to flesh out, but I'd love to comment on a few different things. One, I love the taking a beat for everybody to reflect on their own inner bully and inner victim, and to really try to have more empathy. When we see someone acting out as a bully, in quotes, if we have experienced being that person ourselves, we can often relate, hey, the reason that happened, the reason I was acting in that way was because I was sleep deprived, hangry, PMSing, and then I was late for work, and I was under time pressure, and I had the pressure from the client as well, wanting to know the answers. There are all these things that are pushing the pressure cooker, or it could be, a variety of factors. Just like when I really like studying personality, and I think helping people connect with their own personality often helps us spot patterns of what drives the behavior. So for instance, a perfectionist type of personality might say, what drives me to be kind of a bully is that I just want things done the right way. So sometimes I feel righteousness, even though I have no time pressure, I'm well slept. I just see that the bar I expected for anybody to hit, including myself, is up high. Mm-hmm. When anybody falls below that, I berate them the same way I berate myself. So I'm also a bully to me, and it just bleeds out to other people. Or maybe a type of person who is more of a helper-giver type. Their bully comes out when they just want to really help you, and they're pushing their help on you. You're hey, I got it. You can back up. And they're yeah, but no, I'm going to help you. And you're dang. So understanding our own inner motivators and what really tends to send us over the edge, or what pushes us to do the behavior, can help us soften. Because I think a lot of working with our own inner bully is not to berate ourselves about it, is to soften and have tenderness towards that. Because most bullies are hurting. They don't like that they do it. They feel bad. They feel shame. I didn't mean to, or I wish I could control that more. And I also love that you mentioned on the kind of victim side, I think a lot about boundaries and how we just monitor our side of the street, because we might not be able to affect other people's behavior, but we can decide, one, how do we respond to the behavior? And two, on the inside, how long do I hold on to that? Am I going to perseverate on that for days and days and days? Or am I just going to toss the ball back over there and say, you know what? That's something that I'm not going to spend a bunch of time on. I'm going to do some self-care and move through this and try not to let it affect my self-esteem. Because I think that's part of the cycle, is that a victim can go down that rabbit hole. There's something wrong with me. I'm so bad. Like, why didn't I try harder? And is that really a helpful line of thinking? Or is it more saving that energy to have a reparative conversation if possible?
Yes. Yes, absolutely. And I think that, you know, if it's someone that you have already approached them, had multiple conversations with them, nothing's changing, it might be that that person either is incapable of changing or doesn't want to. But if you've never vocalized it or verbalized it to them, you know, that's also that's an issue. And I think that thinking about the impact, just big, broad overview impact of this. You know, in our talks, we've gone into many specific examples of this, but I think what it boils down to is that the impact is there's trust that's broken. There's silo formation at work. So I think that the more that we can, in each of our spaces in this profession, private practice, industry, academia, the more that we cannot think of it as, oh, the technicians and oh, the doctors and oh, the front desk staff, I think the more that we can get real self-aware, understand that when we silo form and we start feeling uncomfortable and we go to just our friends and we're gossiping. I mean, gossip, we could do a whole, hour just on gossip in the workplace as being destructive. But when that behavior starts, what is really happening is that we are failing our patients because turnover rates go up. And turnover is real expensive, right? So then the hospital's going in the red. And then it's this vicious cycle of trying to hire more. And then it can be hard to hire and retain when you're in a cycle of turnover. And people are saying, wait a second, why is there all this turnover? And it is like the death spiral, right? And so I think that the more we can recognize that we have a common mission. So as a team, we have a common mission and we want to provide the best patient care. And in order to do that, we need to communicate with clients and we need to communicate with each other well. And we need to admit that we're human beings and we're going to mess up sometimes, and we need to stop expecting perfection of others and of ourselves, because that's, I think, where it all stems from. And as someone who is like, I call myself a recovering perfectionist, that's hard to do. It's hard work. But the impact is, the stakes are too high. And I think that, I've been talking too long, so I'm going to let Kate talk about this next part. But I think that we talk a lot about bad mental health in our profession coming from clients, and we ignore an elephant in the room, that it is not just the clients. So yeah. And Kate, I don't know if you want to, kind of tacking onto that, like the impact, beyond just patient care too.
Yeah. I mean, I think that, one of the things, like, since we originally started this conversation, we just sort of have an awareness of these interactions, and anything from like, entertainment, television that we're watching, to just meetings that we're in, or, posts on social media, that there's just like, it's just so prevalent. And, what's really interesting about the people that can reflect on their own behavior and also make a change was a really important reminder that even people who are really struggling with problematic behavior or bullying, having an impact on other people, that they are capable of reflecting and changing. And so I think it's more important than ever. We work with a lot of people that are described as, well, that's just how they are, or that's just that person, don't take it personally. And I think that's unacceptable, because I think, two things. One, just to be told that that's the assessment of that person doesn't mean, has anybody ever had a conversation with that person to say, hey, these are my observations, and more importantly, this is the impact that it has on me. Because there's somewhere a disconnect between people's, doesn't matter what your intention was, but really what the impact was. And I think that people really struggle with that part, which is just to think, well, I can't control that, but I do think that you can continue to do better and be aware of your impact on others as you would want for yourself, with the people around you. So I think you have to have conversations. You have to at least give people grace and think that they haven't been told about what the impact of their behavior has been on others unless you have personally had that conversation with them. And if you haven't had that conversation with them, then I think you can't expect a different outcome. So I think that there is remarkable capacity for change if people talk about it, but there's a lot of defaulting to policies around people or conversations around people, or you have sometimes somebody who exhibits this behavior, probably through some of the description about it's self-protective, they're hanging on to their skill set, their importance, their value in the workplace, that there's a lot of turnover sometimes around these really very capable, very skilled, valuable people in terms of what they can do. And yet that the impact on the team and the turnover around them, like there's a metric. You can look at that and see that. And so why not have that conversation with people and talk about that? And I agree that in vet med, it's very comfortable to talk about what the clients, like their influence on our happiness and our satisfaction, and that we attribute concerns about suicide in vet med to how clients interact with us. And I think that clients are maybe 20% of it. And that whether it's our imposter syndrome or the interactions that we have with others, or just so much that we can improve upon, that actually plays a greater role. And I say that from the perspective of having lost a few people to suicide now. And these were not individuals that were in client-facing roles. So I think that's really important. And a lot of that came from the behind the scenes, the interactions, the way that people were made to feel, whether it was the intention of the folks around them or not. That's just how it came across. So I think that we're obligated to do better.
I've seen the same thing. Like my experience working within vet med echoes exactly what you're saying. I think the majority of the pain and the friction is internal to the clinic, the relationships with the team, and our own coping, the things we've been taught, like how to interact. We just haven't had the education or the time. And I think that a lot of times we have policies that are just plopped down without any real effective implementation or understanding. Mm-hmm. So it doesn't, you're not going to policy this. You're not going to policy your way out of this. This stuff takes actual real hands-on practice, just like learning a surgical technique. This can be cumbersome and awkward and weird when you try to learn it. You're going to mess up a lot. It takes a lot of repair. It's messy. It's vulnerable. So people are like, I don't know this. It's like you just keep going the path you've always known. But we can call it, you finally label something and have a name. And I also like to really talk to people about, instead of labeling a person as a bully or a victim, we might use behavioral language. They have a bullying behavior. What does that mean? The behavior was they used a loud tone of voice. Like be very explicit and objective rather than a global word. And that way it's like behaviors can change. We're not just labeling you as a human that should be, tossed to the side because you can't be changed. Behaviors evolve constantly. Like we know that with animals. Like we're always teaching people behavioral interventions with their pets. So we're animals too in that way. We can evolve our behaviors. And I think that commenting on the suicide is an aspect of this, the pressure that drives people to such extremes. It's definitely worth being a part of this conversation.
Mm-hmm. Yeah. And I think there's a narrative, going back to the self-awareness piece too, right? Like there's a difference between the narrative that we tell ourselves about the scenario, versus what that person who has, offended you actually might be the intent or what they might be going through. And so I think that it's a truthful statement to say that, as the technician in scenario one, I felt like insulted, demeaned, like a bit demoralized. But it is unfair for me to say Dr. Aicher meant to, like, she hates me, And I think that's the story that we tell ourselves a lot without having that conversation. And I think the other impact, before we shift to solutions for kind of the final part of this session, the other impact would be on our trainees, like if trainees overhear certain conversations that are happening. And I know Kate and I had talked about a colleague, there's a social media post that we given an example of that actually I think we could read here that would be really powerful. And then another example of kind of a trainee overhearing something and then that changing their desire to go into academia. There was Kate, I pulled it up. I have this, I'm going to read that post, the social media post. So This is a social media post that we found of a veterinarian. And she says, long story short, I quit after a few months after bullying behavior from another doctor. She said I didn't belong there. My knowledge base was weak and I lacked confidence. I usually run into this issue with X demographic of people in the profession who seem confident and much more outspoken than me. My burnout from this profession doesn't come from clients or cases. It comes from mean colleagues. What would it cost this doctor to help me with my cases and knowledge base? This person didn't get to know me at all or understand, who I am, my background, reasoning in those scenarios. They were quick to judge and spew horrible things about me. And I think a lot of people listening could probably relate to that. But powerful quote, I think, speaking to burnout and the colleague interaction. And then, Kate, I don't know if you wanted to share that story of, a colleague of ours being a trainee and what they overheard.
Yeah, the colleague was me, to be frank, and it was when I was the resident, and I had gone to another service in the hospital to get an opinion, insight consult on case. And while I was waiting to be able to speak with the two faculty members, whichever one of them was going to be able to talk about cases, the two of them had a conversation, and I feel very certain they knew I was there, but who knows? I didn't ask, like, hey, do you know if I'm here? Because this is awkward. But the two of them just started speaking about another resident at the time. And the conversation was like, do you think that this person is less of a screw up now? Like, is there any potential there? I mean, it was just really pretty remarkable how comfortably they were speaking and about, and not in an objective way. Like, I think that this person lacked confidence or really needed to organize their thoughts, or these were the things. Do you think that things are better? But it was very like, do you think this person's less of a screw up? Is there any hope? Probably not, and I thought to myself two things. One, now I have to present this case to you and hopefully do it in a way that when I walk away, I'm not going to hear this or think that that's being said. And also, what if there were two other faculty members that were having that conversation about me? So it was just a really an important reminder of how comfortably people have conversations about people. And I think that if you just spend your days having conversations either with people about the concerns, or you are only speaking such that if that person walked into the room or could overhear you or any of those things, that you were speaking in a way, it doesn't mean we can't hold people accountable. And be objective about what the concerns are, where the opportunities are for improvement, or where we were disappointed with how things went. And you can do it from a position of caring, and from just a human being perspective to think, like, how would I want to hear about this? So I think there's a lot there. Emily and I have spent a lot of time talking about people talk about wanting to avoid conflict, that they just are like, I'm a conflict avoider, I can't do it. And, and I think the thing is, well, then you can't get out of bed and go do anything because there's conflict everywhere. So if you want to figure out a strategy that
life, welcome to life.
Right. I mean, I'm going to have conflict with my dogs in the house. Like, they're going to want an earlier dinner time, and I'm going to say, negative, it's 3:30. We're going to at least wait until 5. I think conflict is everywhere, and we can have healthy conflict by addressing it in a healthy way and sitting down and having conversations. And I really, when I think about people's capacity for change and empathy, I think sitting down and having people who are in conflict with each other, just hearing, like, what's your perspective? What's your perspective? What are your top concerns? And just the opportunity to hear what somebody else is going through. You can't know, you can't assume, you're always going to get wrong. But if you can sit down and take the time and have those conversations, I think it's really remarkable how much change can come from that. And so I think our hope is thinking that those are things that people can do, and folks are listening to this, then maybe they can find the strength to try to do those things. They are hard conversations to have, but that's like the reward on the other side is just makes it so worth it if you can put in the time and some of the courage to sit down and start that conversation.
That's probably why we like teaching it so much. It's one of our core, like, we have different modules that we teach on, like burnout is a big one, managing the stress cycle. I never say resolving conflict. I say managing conflict. It's just management. Forever process. And it's a skill that can be learned just like any type of medical skill that you've learned. If you've proven in vet med, you're good at learning. I guarantee you can learn it. And everybody has their own kind of style and flavor of it. But the cool thing about it is there is a science and an art to it. So I think once people are, brought to the lesson and say, oh, there are these steps in different ways, and you can try them on, and then you can feel the result of like, okay, this is getting more comfortable. Once you become familiar, you start to see the different ways to manage and work with conflict. You can also see exactly what will make it worse. Like, I know exactly what I could say right now that'll make it go off the tracks. And I also know what I could say to help us reduce the friction and create more understanding. So I think that's a really, really nice thing, is just to remind people that all of this has been studied ad nauseum. There are many people out there that enjoy teaching people these skills. It is learnable, and it gets easier with time. The more you practice, the more you can say, nobody loves conflict, but they say, I'm pretty confident with it. Like, I'm fine with managing it. I don't love it, but I can do it.
Yeah. Well, and that's where I think things like disc training and some of the other methods to help understand how your teammates communicate, how you communicate, this is why this person responds like this in this specific scenario, because they're a whatever combination of letters or letter, but anything you can do as a team. And, we've already touched on, I think, a lot of solutions, but I think core things are normalizing healthy conflict, understanding that's inevitable, moving it forward in a productive way. And I think that the institution being supportive of systems to handle these types of situations, especially if they are becoming repeat offender scenarios, right? Where I would argue, I would say it's less common that you're going to actually have those people that are intentionally bullying. If you were to sit down, have a human-to-human, face-to-face conversation, I think probably I'm throwing a number out there, like 80% of scenarios, I bet that other person is going to be like, okay, this was not my intent to make you feel this way. X, Y, and Z was going on. But I think for the scenarios where it is repeat behavior, where the individual maybe isn't capable of change, the organization needs to have a safe reporting system where there's not going to be retribution, not going to be retaliation, where people that are in a, subservient or lower on the totem pole, position feel maybe comfortable coming forward, because that's the only way we're going to be able to have productive change and to hold people accountable. And if other conversations weren't a motivator to change that behavior, well, a system with a consequence in place to hold people accountable is the best thing that we can do. And I think, just again, going back to face-to-face conversations as much as possible, like, they're not always possible. There's power differentials. There are always going to be extreme, scenarios. But for what we're talking about, the average, that uncomfortable scenario that is hard to put your finger on, a lot of just face-to-face conversation can go a long way.
I appreciate you mentioning kind of the structure too. And this is where I always want to encourage people to get that professional help. Like, if you need someone that really is good with HR and can walk you through kind of the policy side of how to think through things, someone who's good with the operational side of what steps do we take, where do we document it, where is it stored, who needs to be involved. You have someone that's a mediator, like we often serve as mediators, as a neutral third party that can help with stickier things. If you need some CE or educational workshops, just get the whole team involved, the same language, think through a full plan. And that's a really fun thing to put together, is this is where we are, this is where we want to go. What are the little baby steps we need to get there? And then we just start implementing those steps. So no, you don't have to figure it all out on your own. Like, this is a giant whale to eat, and you can recruit help to eat it.
Yep. Checking your ego at the door too. Like, I think that we all have ego, right? Like, it's not just the stereotypical male surgeon who has ego. We all do. We're all perfectionists, in this profession. That's what brings us there. But I think recognizing, like, going back to the word vulnerable, Crystal, that you had used before, and not to go back to the pit, but honestly, it's one of my most favorite shows that I've watched recently. And Noah Wiley's character, there's some really powerful scenes where a trainee catches him in a very vulnerable moment. And then there's conversations later about that. And it's so powerful. I don't want to ruin things for people that haven't watched the show, but there is so much power in human to human connection.
I think it extends, I don't know if there ever would have been a time in my life where I would have been so cynical to be like, I need more training, but I think that it's pretty remarkable. So for the training that I've had, emotional intelligence or thinking about conflict resolution, that I spend a lot of time thinking, okay, I'm upset about something. So instead of just being like consumed by thoughts and feelings on this journey, out of control, not being my best self, like the idea that I can recognize and stop and think, okay, I'm upset. But upset could be, I'm scared, I'm mad, I'm furious, I'm insecure, I'm melancholy, that there's so many different things. And so I think it has been beyond just work, but even outside of work to say, why do I care? I'll say, hey, Kate, why do you care so much about this? Like, what's your skin in this game? And a couple of things will happen. One, I'll try to be able to figure out exactly what it is that I feel, even if that's just something as simple as like, out of these 50 emotions, which one of these am I actually feeling? Which can be eye-opening. And then also sometimes to say, is this worth my energy and effort? Like, why do I care this much about it? Does it matter? Does it really matter? Like, what's my skin in this game? And I think that if more people started to get to have those tools in their toolbox, that not only would work be more enjoyable, but really everything in their life would be, I think it would just really control it, but just really focusing on like, what are the things that we can control? Because there's a whole heck of a lot of things we can't. And when you can dial that in. And so that's where I think that cynical Kate maybe would have been like, I don't know what the value in this is, but current Kate who gets to feel a lot more control about those things than she would have in the past before understanding that, I think really is grateful for having that perspective now. And it's still a life with challenges, but it's far fewer that are unnecessary.
It reminds me of the word wisdom, right? As we mature, we hope to also become wiser. I think a mark of wisdom is having that ability to step back and reflect and pause and make decisions from that place rather than being reactive, and that's a part that it doesn't necessarily have to come with age either. I think wisdom can be imparted on us earlier in life if we're lucky and we go for it. But I think some of this type of education on things like you said, emotional intelligence, personality typing. I love the Enneagram. I'll promote that one. Conflict resolution, stress management, all these things help us understand ourselves better and have more empathy for others as well, right? And that's, I think, where kind of wisdom starts to generate that space, the fertile ground for it. And I appreciate you all bringing this topic today. I think that it's been a really nice journey of being able to walk through the impacts that it has on the team and ourselves and on life at large, trying to like destigmify bullying and understand that we all have that experience, both of being bullied and being the victim, walking through a lot of the great research and giving those scenarios that bring it to life so we can all feel it in our bones, what it's been like, and then walking through a bunch of the solutions. I'm wondering for people listening today, if you all want to impart some of your wisdom on them. For a lot of us who are very busy, we may not be able to retain as much information from podcasts as we hoped. If you want people to leave here just remembering like one or two really big nuggets, what do you hope they latch on to from the podcast today?
I would start with saying that I think folks should actually be aware, like no one's immune to their bullying behavior. So is it that you somehow turn into a different version of yourself when you're at the airport and you learn that your flight just got canceled for the third time? And now this anonymous interaction that you're going to have with this gate agent or person on the phone, like maybe that's where the nicest person, the wheels come off the bus. So stopping and thinking really about the idea of thinking like, where do I have growth and where can I slow down and be the version of myself that I want people to know me by or identify me by. Mm-hmm. That would be one. Everybody.
Yeah. And then I think that, we've already kind of hammered in the normalizing conflict. I think workplaces, for those that are listening that are on, leadership teams, hospital managers, et cetera, conflict is going to happen. And I think thinking about things that, add fuel to the fire would be like ignoring it is probably not the way to go. And it's not easy. It's hard. And then probably minimizing gossip in the workplace. We didn't spend a lot of time talking about that today, but that is a huge issue that is just like a brush fire, in any, especially large workplace. And I think that in our profession, we have a lot of large workplaces in every facet of vet med. And so again, human to human conversations, being as direct and clear as possible. Clear is kind from Brene Brown. I think that's really, really important. And we're all human beings.
So well said. I appreciate you being on today and sharing this topic. It's really meaty. I think you did it justice. I hope those listening today will get excited and start looking into this. In our show notes, we're going to share a bunch of resources that you've shared with us. So for those of us listening who might be a little nerdier and want to dive deeper, I'd say check out the show notes to this episode. And for people that want to reach either of you, what's the best way for them to get in touch? And I can put that in the show notes too. Email?
Yeah, probably our email addresses, which we can get those to, Crystal. I don't know if you want me to say them out loud right now, but I think we could just have you. Yeah, email is great.
Okay, so I'll put the email in the show notes too. So anybody that wants to get in touch with either Kate or Emily, you can reach them directly. I encourage you to reach out. And just again, thank you so much for being on with me today. It was really fun.
Thanks for having me.
You're welcome.
Thank you for joining me today. I hope that you feel stoked after listening to this episode. And as always, I would love to hear your comments and feedback. Is there a topic that you want to know more about? Please let me know. And thank you again for subscribing and sharing your favorite episodes with others. It really means a lot.